are in listen-only mode.
All right. Good afternoon. I'm Lorna Lucas, Assistant Director of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Ms. Catherine Schott, our expert presenter for the 9th eCourse of the series, hosted by the Institute for Clinical Immuno-Oncology, also known as ICLIO, who will discuss coordination of care for immunotherapy patients in the community setting. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by cancer immunotherapy. It includes other vital resources such as newsletters, papers, our Scholars Program, and a national conference which will be held September 30th in Philadelphia. Please visit www.acc-iclio.org to browse all of our offerings. Now for today's eCourse, I'm pleased to introduce Ms. Catherine Schott, Immunotherapy Coordinator at Wheaton Franciscan Healthcare. Ms. Schott has been a registered nurse practicing in oncology since 1989 and has spent approximately 14 years as an immunotherapy program coordinator at Aurora St. Luke's Medical Center in Milwaukee, Wisconsin. The focus of her work at St. Luke's has primarily been in the care of patients with metastatic melanoma and renal cancer. Ms. Schott coordinated care for FDA-approved immunotherapy regimens and clinical trials. Her clinical trial coordination was primarily in immune oncology agents and included pharmaceutical trials, cooperative group trials, and investigator-initiated trials. Ms. Schott's most recent work experience at Wheaton Franciscan Healthcare, along with Jonathan Treisman, has started an immunotherapy program consisting of FDA-approved immunotherapy regimens and clinical trials. Her research interests are in furthering cancer care and treatment with novel approaches. Now for a few housekeeping notes. Please feel free to submit questions to our presenter by typing your questions in the box on your dashboard. We will address the questions at the end of the webinar. We'll also be joined by Dr. Jay Ginto. The webinar will be archived and available on the ICLIO website within a day. Now I'll send it over to Ms. Schott to kick off the webinar.
Hi, thanks for having me and for being here today. I'm looking forward to being able to speak to you about the care coordination for the IO patient. I've actually always been based in the community setting since the beginning of my career, and one of the physicians I worked with and his partner began an immunotherapy program at a local hospital in Milwaukee that I worked at. And at the time it was really appealing to me because I wanted to really help find better ways to treat our patients. So at that time, most of the things that we were doing were in clinical trials and they were inpatient. We were doing high-dose IL2, LAC cells, and TIL cells. So it's really very exciting to be moving into the outpatient setting with some of these regimens. Next slide, please. As far as conflicts of interest goes, I have no conflicts of interest. Next. So our objectives today is that I'll give an overview of FDA-approved IO agents. I think that we forget that we've actually been using a lot of immunotherapy agents already. I think the buzz is really the newer agents that are most exciting. What is the role of the Immunotherapy Coordinator? Patient selection, access to IO agents, financial concerns and reimbursement, staff and patient teaching, and adverse event monitoring. Next slide, please. So as far as the FDA-approved immunotherapy for cancer treatment, we have nonspecific immunotherapy, which is BCG for bladder cancer, and many researchers think that BCG stimulates some form of anti-tumor immunity, but really the exact mechanism is not understood. Then we have our cytokines, interferon, which probably many of you are familiar with in the outpatient setting. And then there's high-dose interleukin-2, which is actually an inpatient treatment, but in the past in clinical trials there has been low-dose interleukin-2 given, and in the future, I wouldn't be surprised to see some trials coming out in combination with low-dose IL2. And cytokines really are attempting to regulate the cellular immune mechanisms, and they can either stimulate or inhibit the immune systems. Then there's monoclonal antibody therapy, and there's just really so many of them. You have your naked monoclonal antibodies that really are just antibodies that work by themselves. Then you have your conjugated antibodies, which are also referred to as tagged, labeled, or loaded. Your bispecific monoclonal antibodies that have a combination of two different antibodies. And then really kind of the more exciting ones most recently are the immunomodulatory or checkpoint inhibitors. So this includes your IPI, nivolumab, and pembrolizumab. And then there's the cancer vaccines that are intended really to delay or stop cancer cell growth and cause tumor shrinkage. What I find with the Sipuleucel is it's listed as a cancer vaccine, but also in some ways it's really a cellular therapy because you are doing an apheresis and collecting those cells and then sending them for processing. So I just think that's kind of an interesting category. Next slide, please. So the role of the immunotherapy coordinator is an option. Otherwise, having one person coordinate the multiple components of the care continuum really may be helpful. So beginning the coordination process as soon as the patient is identified in order to help prevent treatment delays is often of interest. So the immunotherapy or care coordinator generally is the primary contact for patients. They'll organize and pre-screen eligible patients for IO regimens, and these can be people that are entering the institution for the first time or patients that have been on multiple prior regimens within the practice and now are maybe eligible for IO regimens. We're to connect patients with the financial advocate for early billing and explanation and any intervention, to coordinate patient care and follow-up, including their tests, procedures, and consultations, and to educate staff and patients on potential adverse events for timely intervention. Next slide, please. So care coordination should begin with screening patients. Begin with a patient interview and a review of the medical record for pre-existing conditions or prior adverse events. This is really important because oftentimes either the medical record is incomplete or the patient will forget a portion of their health history. It's especially important to discuss prior history of autoimmune disease and if they've had prior immunotherapy, whether or not they experienced any immune-related adverse events. If anything should be of concern, obviously communicate that screening concern with the treating physician. Often patients with pre-existing conditions or prior AEs were excluded from treatment. However, with more recent literature, they are suggesting that further evaluation by subspecialties and additional workup may actually allow the less than ideal patient to be treated. If you find that you have a patient that falls into this category, it should be communicated and reviewed with the physician prior to treatment, and often additional monitoring is needed. Obviously, use caution when treating those patients, and things to consider would be more frequent communication with the patient, either by phone calls or office visits, and if the patient does develop an adverse event, rapid intervention and close follow-up, and using subspecialties as needed should be considered. Next slide, please. So all patient selection is not the same. For our nonspecific immunotherapy, the BCG patients, contraindicated patients would be considered immunosuppressed patients. You'd want to consider postponing treatment if there's a febrile illness, a UTI, or any gross hematuria. You wouldn't want to initiate treatment for 7 to 14 days following either a biopsy, a transurethral resection, or a traumatic catheterization. And it is contraindicated for patients with active TB. So active TB should be ruled out in PPD positive patients before starting treatment. Next slide, please. And then with our cytokine patients with interferon, we need to screen for significant depression or psychiatric disorder, screen for autoimmune disorders, autoimmune hepatitis, or liver disease. That doesn't mean these patients can't be treated, but it may mean that we need to monitor them more frequently. And then with IL2, you would want somebody with a normal cardiac, pulmonary, hepatic, and CNS function at the start of therapy. Normally, there should be no evidence of CNS metastases, but if they do have that, they should be treated and stable and off of steroids. And this type of treatment is often associated with exacerbating a pre-existing condition or actually having an initial presentation of autoimmune disease and inflammatory disorders. We actually had a patient that had an extremely great response to high-dose IL-2 and subsequently developed rheumatoid arthritis. And whether or not the two are related, it's likely that it could be, but it was something that did happen. Next slide, please. So monoclonal antibodies, there's actually so many on the market that really you need to check the package insert for any contraindications that may be listed. In the clinical trials with the newer agents such as Ipi, Nivo, and pembrolizumab, they actually excluded patients with previously diagnosed autoimmune disease. So this is something that should be considered prior to treatment, but it does not necessarily preclude treatment. It just is a key to make sure that there is a closer monitoring for those patients. Next slide, please. And then for the cancer vaccines, the Sipuleucel, use caution with patients that have a risk for thromboembolic events. And with the Telemagen, immunocompromised patients or pregnant patients should not receive treatment. Next slide, please. Especially as these agents are moving forward into the adjuvant setting, I think we'll be seeing patients that are younger and living longer, and so there may be patients that are still interested in family planning. So one thing is to, obviously if the patient is pregnant, check the package insert for pregnancy information. Most of these agents usually have a pregnancy category between B and D. So really, we don't know what harm could come to the fetus if the woman is pregnant. Lactation is another issue. Most of these agents it's unknown whether they're transmitted through breast milk. So if you would have a mother that is breastfeeding a child, you would maybe want to have the conversation that they should stop breastfeeding prior to treatment. Contraception is also another issue and should be used during and after treatment per package insert recommendations. It can go anywhere, recommendations can go between 3 and 6 months of post-treatment. And then fertility. Fertility studies really haven't been done on many of the newer agents such as the PD-1s, so this is also something that you may want to discuss with patients. Next slide, please. So another concern when coordinating care is the access to IO agents. There's several barriers in accessing IO agents in the community setting. One is low patient volumes. So in smaller facilities and or practices, the limited patient volume may be a concern. So once a patient is identified, notify the pharmacy so they begin looking at obtaining the agent if it's not on formulary. Getting the P&T committee approval, sometimes this takes some time and oftentimes you need a quick turnaround. So the best thing to do is to actually see if your P&T committee will go ahead and give you a case-by-case approval. And then cost is a big factor, especially in a smaller facility or practice. And having agent in stock can be quite costly if it's just sitting on the shelf. So one thing to help eliminate that is to order the agent per patient as a way to keep costs down. Conducting an adverse event phone call about a week prior to the next treatment to assess the patient. What this may actually help do is, if the patient has developed something like rash or diarrhea and does need steroids, you may know a week in advance that they won't be ready for that next treatment. Does it mean that you won't ever end up holding a dose? No, but from a practical standpoint, it can help to keep costs down. Next slide. And then financial concerns. It's really never too early to start the predetermination process. With third-party payers, make sure that predetermination is in place. With Medicare and Medicaid, no predetermination is needed as long as it's being used as an FDA-approved agent. But I know a lot of physicians sometimes are interested in off-label use, and that's then a whole nother ball of wax that you have to deal with. And then get financial counseling involved. Address concerns early to avoid unnecessary worry for the patient. Discuss those out-of-pocket costs, and utilize the assistance programs. Those will actually help to ease the financial burden for the patients that qualify, but often getting the patient enrolled in the assistance program may take a little bit of time, so addressing this early may help to avoid treatment delays. Next slide, please. So as far as assistance programs go, a few of the assistance programs will not actually allow a patient to enroll prior to the insurance denial. So things that people can do up front is to make sure that the patient meets the financial qualifications for the assistance program, and then actually have all of the paperwork and financial information in place prior to treatment. That way, if you submit to insurance and get a denial, you're ready to submit the packet for the assistance program, and there's not a huge delay in that time frame. Once the assistance program actually gets the information, the turnaround time often is pretty quick, just a couple of days for a decision to be made. Next slide, please. So patient education on adverse events, especially in the outpatient setting, is essential. Patients and caregivers should have education that is ongoing to help reinforce adverse events that may occur during and after treatment. We have to always be cognizant that these therapies may actually cause some long-term, late appearing side effects. Make sure that the patient has access to wallet cards and symptom logs. This is really important, especially if the patient presents to the emergency department, because it allows that emergency room provider to really contact the treating physician and consult with a more complete understanding of the side effects being experienced. For example, diarrhea for 1 or 2 days really may not be significant, but if it's a grade 3 diarrhea and they've just had IPI or Nivo or Pembro, they may actually be in need of steroid treatment, and that wouldn't necessarily be the first thing that someone that isn't completely familiar with these agents would think about. And then encourage the patient for accurate reporting of adverse events. Stress early reporting. Patients may be hesitant to do this for fear of being taken off treatment. So really reassure the patient that many side effects can be treated early, and early treatment may help prevent treatment delays. So the main message for your patient is to call early and call often. Next slide. And then there's staff education. Education should include office staff and the triage staff. It's really important for the triage staff to be keyed into these patients, very similarly to why you would key in that emergency room provider of the side effects. You may not necessarily treat the side effects the same as you would for chemotherapy and or radiation therapy. Infusion staff should be educated. There are cases where the physician may see the patient and then their treatment may occur 1 or 2 days later, and even though they were fine at the appointment, they could develop a rash or something else within that 24 or 48 hours until treatment occurs, and so they should be aware of and know to look for things like that. Obviously, your advanced practice nurses and physician assistants need to be educated to manage this because often they are the ones that are covering if the treating physician is not available. The use of treatment algorithms is sometimes helpful for managing side effects, and it's really helpful sometimes when the treating physician is not available. And then just continue to reinforce the staff and patients that late appearing side effects may occur. Next slide, please. So just in my own personal experience, what we've basically seen most commonly with the PD-1s is rash and diarrhea. For rash, we normally will start out with topical steroid cream and or antihistamines. If that rash progresses to a grade 2 or 3, then consider oral steroids with a slow taper, and if needed, a dermatology consult. And then diarrhea is also a very common side effect. So begin if it's low-grade diarrhea with oral antidiarrheals. If that doesn't take care of it, then oral steroids and IV steroids with a slow taper, and consider a GI consult with a colonoscopy and biopsy to rule out immune-mediated colitis. Next slide, please. And then another interesting thing as we're moving into the adjuvant setting, we've actually had 2 patients that were treated with high-dose adjuvant IPI at the 10 milligrams per kilogram for melanoma, early stage high risk for recurrence melanoma. And both patients actually had an onset of skin rash, diarrhea, and then hypophysitis. And it kind of all 3 symptoms kind of rapidly followed one another. And one patient, both patients were sent for MRI of the brain. It was interesting that both patients called and reported having like a severe headache that with shooting pains. They almost described it in exactly the same verbiage, that both patients complained of these headaches, and both were sent for MRIs of the brain. One actually had an enlarged pituitary, the other did not. And then one of the patients also had a biopsy-confirmed autoimmune colitis, the other did not. So the patient that did not have the enlarged pituitary and did not have the autoimmune colitis, we were able to get his symptoms under control, and he continued with treatment. And then the other patient that actually had the enlarged pituitary and the autoimmune colitis, the symptoms were controlled, but we did not continue treatment with the high dose. Next slide, please. So what about care coordination between treatments? It's really important to stress communication with the patient between treatments and after treatment. Regular follow-up phone calls by the clinic staff to assess adverse events. If adverse events are being experienced, daily phone calls or every other day phone calls may be helpful to track severity of symptoms. We had an older gentleman that had all of his teaching done came into the office prior for his next dose and had a grade 3 rash that he had been experiencing for greater than a week and hadn't called. So we were able to get the rash under control, and then after we resumed treatment, I called him about a week after his dose, and sure enough, the rash had returned, but he hadn't thought to call. So you kind of have to gauge if you think the patient will call or if you need to call that patient. Monitor response to medications and interventions, and consider referring to subspecialties such as GI or endocrinology if needed. If needed, increase the frequency of lab monitoring and office visits to assess for adverse events, and then instruct the patient to visit the emergency department if high-grade adverse events present themselves. Next slide, please. And then there's care coordination for travel. Considering that several of the IO agents are given until disease progression or unacceptable toxicity, there's really a good chance that the patient may want to travel while receiving treatment. So it may really be of benefit to provide some proactive management prior to the patient leaving. Instruct patients to bring side effect materials and education materials with them. Confirm that the patient has the contact information for the treating physician, including the after-hours contact. Write prescriptions in advance and encourage the patient to have these prescriptions filled. Prescriptions such as steroidal cream, oral steroids, and antidiarrheal medications are a few examples. Make sure the patient is clear on when to start the medication and how to take them. And then if the patient is able to call while they're traveling, instruct them to call the office and give a side effect update if they begin using the medication. Another thing that's good is to have the patient research nearby hospitals and emergency departments close to their destination. That way, if something happens, they have a plan. And sometimes it's really a matter of a short distance between a very small care facility and a larger medical center. And, you know, that may be nice for the patient to know in advance. And then obviously instruct the patient to go to the emergency department if adverse events are not well controlled. Next slide. And then care coordination after treatment. So once treatment is complete, encourage patients to keep long-term follow-up appointments. Patients may begin to skip their follow-up appointments once treatment is completed, and I think this really may be something that we're seeing more of as the treatments move more into the adjuvant settings. Assess for new adverse events at long-term visits. There's a few limited reports of late appearing toxicities. One such report was a radiation necrosis to the brain after IPI and radiation therapy to the brain, and this resulted in some pretty significant neurologic deficits for the patient. As more patients are treated with IO agents, we need to be vigilant to assess for late appearing side effects, because although the toxicity profiles are well established, long-term effects of immune therapies still really need to be explored on health outcomes. Continue the assessment and management of chronic AEs. According to the literature, the endocrinopathies are the most commonly reported, and they often require long-term hormonal replacement therapy. And then start considering survivorship issues. Survivorship after treatment with IO is really a relatively new topic in the literature, but as the agents become more widely utilized and attention to quality of life, psychosocial well-being, and long-term complications should be considered. Next slide. And any questions?
Great. Thank you. That was a very informative presentation. So we do have a few questions here. The first question has to do with patient assistance programs.
Yes.
And So for those that are unable to afford immunotherapy as a result of not having any insurance, are there cases where these assistance programs are able to cover the entire treatment?
So I actually spoke with our pre-authorization person and financial counselor regarding this. And what the assistance program will do is pay for the drug or the agent, but they do not cover the costs of the office visit, IV draws, the infusion clinic costs. So that would be something that you would then have to probably work out if your hospital or facility has an assistance program for uninsured patients, but it's not something that usually the assistance program is completely paying for. They're generally looking at agent replacement.
Okay, thank you. This next question has to do with the hospital's P&T committee. So nivolumab and pembrolizumab are very similar in terms of mechanism of action, and that they're both anti-PD-1s, yet some physicians prefer using one versus the other. Now, is it possible for both agents to be in a hospital's formulary? And if not, then we assume that the patients can still access these either by a case-by-case basis?
Right. So we were lucky enough that we actually were able to get both on formulary. So the physician is able to have that discussion with the patient about which agent they think, is right for them. But there is no reason that you couldn't, make a case for going to the P&T committee to just get the agent that's not on formulary.
Okay. So you had mentioned ordering immunotherapy on a patient-by-patient basis as a way to keep costs down for smaller facilities. So once a patient and physician decide to go with a certain checkpoint inhibitor as a therapy, when should that immunotherapy be ordered, and how much time does it take for the agent to arrive in the hospital for administration?
So really, we've had a pretty quick turnaround time. So even if we wait for that insurance pre-authorization to come through and predetermination, and then notify pharmacy that it's been authorized, generally it's less than 1 week and we can have the patient on treatment with the drug ordered.
Okay. So this next question has to do specifically with your role as Immunotherapy Coordinator. Now, in other hospitals, can this role be filled by other staff besides nurses, like, for example, pharmacists? And also, are the immunotherapy coordinators, are they just limited to, the newer immunotherapies, such as checkpoint inhibitors, or do they generally assist in the coordination of the older immunotherapies that have been in the market, such as the cytokines or BCG?
Right. So as far as who can fill the role, there really is no reason that role couldn't be divided up. It wouldn't necessarily have to be one person. If it is the triage nurse or an infusion nurse, they would probably be the ones that are assessing the side effects, and then you could have pharmacy monitoring frequency of treatment when drug ordering needs to be taken or done, and those sorts of things. So it doesn't necessarily have to be just one person in the role. If it is one person in the role, I've been doing this since the late 80s, early 90s, and my original role was to follow the patients that were on cytokine therapy, and I continue to follow the high-dose IL2 patients, the interferon patients, as well as now the IPI and then the PD-1 patients.
Okay, thank you. How about the issue of survivorship? So does your institution have any certain programs or a certain way about addressing survivorship, and which support groups or programs would you recommend?
So survivorship specific to immunotherapy is still relatively new, and actually we are just currently working on getting a survivorship program for our immunotherapy patients up and running. And then as far as, I am not aware of any specific online immunotherapy survivorship websites compared to just normal or generalized cancer survivorship websites. So I think that's really still something that is an area of growth as these agents become more widely used.
Okay, thank you. I think that's the amount of time we have here for questions. I'm going to turn it over to Lorna to wrap up the eCourse.
Thank you both to Ms. Schott and Dr. Ginto for the engaging presentation. And thank you to our audience for participating. Again, the webinar and slides will be available on our website, which is ACCC-ICLIO.org by the end of the week. And all registrants will also receive an email, so if you'd like to share with your colleagues, you'll be receiving that shortly. And also, please be sure to register for our upcoming webinars. We have our IO Biologics Process and Issues in Setting Coverage Policy on February 4th with Dr. Brian Loy from Humana. And we also have a combination therapy webinar on February 23rd with Dr. Igor Puzanov from Vanderbilt. So thank you so much for participating and hope you have a great day.